Hello, it's Andy Shore from Washington, D.C. with your Pulmonary and Critical Care Literature Review for the month of August. There are two articles that have recently been in JAMA that I want to share with you. I think they bear directly on the practice for those of us who are actively involved in the care of critically ill patients or working in hospitals for quality improvement or quality assurance. The first one deals with tight glycemic control, and the second one deals with ventilator-associated pneumonia. Both of these areas have been key efforts for focuses of process improvement and of quality of care. In fact, CMS, the Centers for Medicare and Medicaid Services, have suggested that hospital-acquired pneumonia, for example, is such a preventable disease that it will no longer reimburse for it. And organizations such as JACO are now holding hospitals to very high standards when it comes to tight glycemic control. Both of these articles bear directly on these issues, and I think give important information to clinicians in terms of what options are available to them and where we know the science is currently going and what we actually understand and what we don't understand. The first article by Soiles and colleagues dealt with the issue of tight glycemic control. They performed a meta-analysis of randomized controlled trials that looked at tight glycemic control predominantly in critically ill patients and its effect on outcomes. As you all recall, based on Vandenberg's article from 2001, there was a strong push to enforce tight glycemic control based on the benefits they showed in that trial. That trial was criticized in that it was predominantly only in a surgical population and that many patients were receiving TPN, which some have referred to as total poison nutrition. Hence, the benefits they saw were artifactual relative to the potential for things they could have done other than just tight glucose control to improve outcomes. However, based on that study and some other data, predominantly observational data, tight glucose control became a very strong recommendation in the Surviving Sepsis campaign. And again, many hospital organizations that accredit and assert or assess for quality suggest that tight glucose control is an important thing for us to do. Well, when these investigators looked across these 29 trials, encompassing over 8,400 patients essentially, what they found was that tight glucose control had no benefit on mortality. They conducted a number of sensitivity analyses to try and get to any potential signal in terms of benefit. So they looked at moderate control versus very tight control with continuous insulin infusions, and again, they saw no benefit. They looked at certain risks or certain adverse events beyond just mortality, such as need for dialysis, and they saw no benefit. Where they did see a benefit was in a group of critically ill patients in terms of prevention of secondary sepsis. Realize, of course, sepsis was defined differentially across all these trials. As clinicians, we always balance risk with benefit. What did these authors find in terms of risk? Well, when they looked at risk, what they saw was that there was a substantial increased risk for hypoglycemia in patients who were being given or treated with tight glucose control. Now, that's not at all surprising in one sense because, of course, the more aggressive you are with blood sugar control, the more opportunities you have to bottom out. The problem is many critically ill patients or hospitalized patients are not going to tolerate hypoglycemia well, and although there was no difference in terms of mortality detected in this trial, none of these studies reported on issues with cognition or CVAs as endpoints in terms of what are the potential complications of prolonged hypoglycemia, especially in critically ill patients. The authors concluded from their work that tight glucose control really isn't ready for prime time, rather. They suggested that if there was no signal in terms of benefit among 8,000 people, including several trials that were stopped early for potential harm, that we really need to go back and re-examine this issue. I think the things may be a little bit more nuanced than that. The prevention of secondary sepsis is an important issue in critically ill patients. I think the days of liberal glucose control in terms of letting them float is probably gone because, again, there are biologic reasons to think that hyperglycemia is an increased risk for infection. The question becomes balancing things. And it may be, at this point, a limitation of our technology, whereas if we're monitoring blood sugars once hourly, lots of things can be happening in between time points that we're not aware of. And of course, patients are differential in terms of their ability to tolerate hypoglycemia. Newer technologies are in development to allow us to assess glucose more continuously, and that may offer us new opportunities to go back and revisit this question. And in fact, at this point, under the auspices of an NIH grant, there's a large multi-center clinical trial that's getting started or is underway to look at this issue in a broader multi-center experience. And I think both of these articles get us to question what we think we know about critical care medicine and about pulmonary medicine, and they actually make us think about what we're doing for quality assurance and prevention in terms of trying to keep up with the issues. Thanks so much. Have a great month. And this is Andy Shore from the Washington Hospital Center signing off.